Hello everyone and welcome in a new endodontic video. My name is Mohammed Al-Halawani and I am an endo addict. To be a good clinician, you need to rely on a series of steps, beginning with an accurate diagnosis, upon which all subsequent steps are built. Given the importance of this step, which is often overlooked and causes significant suffering of the patient, I have created this series of 7 parts hoping to succeed in covering everything required to reach an accurate diagnosis. In the first video of this series, we will explain how to obtain all necessary information about a patient complaint. Then, in part 2 and 3, we will discuss the patient's medical history and its impact on oral health. In the fourth video, we will see how social life and the family history affects the patient's oral health and the treatment plan. This will be followed by a brief explanation of how to examine the dental patient. Finally, in the last 2 parts, we will review the necessary investigation methods and the tests to reach a decision. So, let's start. So, what is meant by diagnosis? Diagnosis is defined as the utilization of scientific knowledge for identifying a diseased process to differentiate it from other diseases. From this definition, it becomes clear that we rely on a set of steps to reach an accurate diagnosis, starting with the precipitation or prediction of number of diseases, or as we say, differential diagnosis. Then the process of elimination begins, leading to final diagnosis. Therefore, the type of diagnosis can be divided into 3 categories. These categories come in order as we have more information related to patient's complaint, moving from one category to another. The first type is called tentative diagnosis, or it can be called provisional or working diagnosis. This type of diagnosis depending on the clinician experience, academic knowledge, and the ability to connect the symptoms described by the patient to the possible disease. However, it can provide any confirmation of any diagnosis because it requires gathering more information through clinical examination and the results of tests and investigation. Next is initial diagnosis. Initial diagnosis is the early judgment of dentist makes about the patient condition based on history, symptoms, and the initial examination before doing detailed tests. We can say that it's a starting point that guides what tests or order, what problems to focus on, early treatment decision, and the last piece is a definitive diagnosis. It's the final, confirmed diagnosis made after all tests and investigations and the examinations are completed. It is the diagnosis that the dentist is confined about and uses to create a final treatment plan. This can all be summarized as a diagnostic process consisting of 4 steps. Step 1, gathering information. First, we collect everything: the patient's chief complaint, medical and dental history, clinical examination, tests, and investigation. This gives us the full picture. Second, interrupt the clues. We put the pieces together. We analyze the signs and the symptoms to form a tentative or provisional diagnosis. Third step, create a differential list. We think for all possible diseases that could explain these findings. This is our differential diagnosis. And the last and the fourth steps is choose the most likely diagnosis. Finally, from that differential list, we select the conditions that the best fit with all evidence. This becomes our working or definitive diagnosis. Let's begin by gathering informations and understanding the effect of each piece of information on oral cavity. As is clear, this is all the information that need to be gathered to reach the correct diagnosis, beginning with patient chief complaint, taking histories, examination, and investigation. The first and most important step is understanding the patient chief complaint. Write the complaint exactly as the patient say it, not as your interpretation. After recording the main complaint, we ask a patient about the history of his complaint. This information can be obtained by asking appropriate question, which should cover the following points. First point, the site. The location of the pain gives an important clues because different dental conditions affect a different area. So asking where exactly does it hurt is essential. If local pain, usually from the tooth or nearby tissue. If the patient points to one specific tooth, the problem often is caries, pulpitis, cracked tooth, periapical infection. Localized pain equal localized disease. On the other hand, despite diffuse or poorly localized pain is most commonly pulpal in origin, diffuse pain can also come from tissues outside the tooth, often felt across several teeth or whole quadrant, and it's called non-odontogenic pain. So, how to differentiate between odontogenic and non-odontogenic? This is one of the most difficult challenges we face, but it's not impossible because it has a keys. One of these keys is the location of the pain. If the patient says it hurts somewhere here, but I can't tell you which tooth, it's mainly odontogenic. But if the pain doesn't match dental finding, you should suspect that the pain comes from non-odontogenic origin. The second question, we ask the patient about the onset. When did you notice the pain? Understanding when the pain started give essential clues about the type and stage of the disease. A sudden pain usually indicates a recent event affecting the tooth structure or pulp. For example, cracked tooth, acute apical abscess, trauma. But gradual onset pain often indicates a long-standing, slowly progressing condition. And we can find that in deep caries progressing toward the pulp, chronic pulpitis, chronic periapical disease, sinusitis-related pain. Onset of the pain can also show disease progression and helps to determine the current stage. And we can see that when patients describe that it has a pain turned from mild to severe, as this case when reversible pulpitis progress to irreversible pulpitis. Onset can also eliminate a lot of confusion and wasting of time. When patient describes that pain appears only when stimulant like cold, hot, bite, sweet, and so on, stimulus-related pain helps identifying the exact diagnosis because you can simply recreate this painful stimulus. Now, let's talk about pain characteristics and how they guide our diagnosis. First, When patients report a sharp pain, this usually means the pulp is still vital. We often see this in reversible pulpitis or exposed dentine. If the pain becomes dull or throbbing, this tells us that the inflammation is deeper. This is a classic feature of irreversible pulpitis, where the pulp is significantly affected. When the patient experiences spontaneous pain, meaning pain without any trigger, this is usually points to a more advanced preapical condition, such as acute irreversible pulpitis or early abscess. So overall, the character of the pain tells us a lot about the cause and the severity and the stage of the dental disease. Now, let's look at a pain radiation and why it's matter in dental diagnosis. When patient tells us that the pain spread over or it's felt in another area, such as in the ear, in the neck, or even on the opposite arch, this is called the radiating pain. Radiating pain is usually a sign of vulval origin, especially in irreversible pulpitis. The reason is that the trigeminal nerve has an overlapping nerve pathway, so the brain cannot always identify exactly which tooth is the pain coming from. As a result, pain can be felt far away from the acute source. Radiating pain helps us clinically because it tells us that the problem is likely palpable than periodontal. The disease may be advanced, involving deeper inflammation. Radiation to the ear or jaw joint may also suggest non-odontogenic cause, such as temporomandibular disorders or neuralgia. So understanding the pattern of radiation helps us to differentiate pulpal pain, TMD, neural pain. But keep in mind, because of this phenomena, the patient might misidentify the tooth. So we must always rely on clinical tests, not the patient pointing. Association refers to other symptoms that occur together with the pain, such as swelling, fever, bad taste, difficulty chewing, or sensitivity to hot and cold. These associated symptoms helps us understand the cause and the stage of the disease. For example, pain with the swelling usually indicates the spread of infection or a preapical abscess. Pain with bad taste may suggest a draining sinus. Pain with difficulty biting often point to a cracked tooth or preapical inflammation. Pain with fever and malaise indicated that systematic spread of infection and they require an urgent care. When we talk about the time course of the pain, we mean how the pain changes over time. When it started, how long it lasts, and whether it's getting better or worse. This timeline gives us important clues about type and stage of dental disease. For example, short brief pain to cold usually suggests irreversible pulpitis because the pulp is irritated but not yet irreversible damage. Long-lasting, lingering pain after hot or cold indicates irreversible pulpitis, meaning the pulp is inflamed to a more advanced stage. Pain that starts mild and becomes progressively worse suggests disease that advancing, such as deep caries approaching the pulp. Pain that becomes spontaneous over time is sign that the pulp inflammation is severe and now require root canal treatment. And pain that disappears suddenly can indicate that the pulp has become necrotic and the pain has shifted to be a preapical tissue. So, the time course shows us how the disease is evolving. Another point, exacerbating and relieving factor. This provides a strong clues about the underlying dental condition. Exacerbating factor, what increasing the pain? Cold makes the pain worse, such as reversible pulpitis or exposed dentine. Heat worsens the pain, indicating irreversible pulpitis. Biting increase the pain, point to the cracked tooth or periapical inflammation. Chewing in the one side hurts, suggests an occlusal problem or cracked tooth. Lying down or bending forward worsens the pain, may indicate sinus involvement. Another factor is relieving factors. What reduces the pain? If the cold relieves the pain, often seen in irreversible pulpitis, because the cold reduces the pulpal pressure. Pain gets better when avoiding chewing, does make us guess that the periodontal or preapical tissue is the cause of the problem. Position changes relieves the pain. Can be if a patient said that when he changes his position from standing to sitting, from lying to standing, that means that the pain is related to the sinus. These clues tell us about the type and severity of inflammation. Another important point of patient chief complaint is pain severity. It's another important factor in dental diagnosis because it helps us understanding how advanced the disease is and how urgently the patient needs treatment. Mild pain usually indicates an early problem, such as reversible pulpitis, exposed dentine, mild periodontal irritation. Moderate pain suggests that the problem is progressing, for example, deeper caries, developing irreversible pulpitis, early periapical involvement. But severe pain is a strong sign of advanced disease, such as irreversible pulpitis, acute periapical abscess, severe periodontal abscess. Severe pain can also indicate that the need of urgent or emergency treatment. But how we may measure the pain severity? Because the pain is subjective, we use pain scales, and the most common methods are visual analog scale or VAS. This is a 10 centimeter lines from 0, no pain, to 10 is the worst pain. Patient marks their pain level on the line. This scale is very useful for research and clinical monitoring of the case. Another scale is numeric rating scale. It's a simple 0 to 10 scale. This works well with dental clinics. 0 is no pain, 10 is the worst, inimaginable pain. This is the most commonly used method in the dentistry. Just ask the patient, can you describe the pain if you can describe the severity of the pain between 0 to 10, give me a number, and the patient will tell you. Another method or another scale, which is based for patients patient has a difficulty in communication, like children, is the faces pain scale. This scale is using faces expressions from smiling, which is represent no pain, to crying, which is equal 10 in the other scale, or severe pain. All the points mentioned above are important, and none is less important than the other. To make them easier to remember, if we take the first letter of each point, we will find that it's the same as the name of the famous Greek philosopher, Socrates. So, remember, Socrates is the questions you need to ask the patient about his chief complaint. And now, we came to the end of the first lecture. Thank you all for watching this lecture. I hope you found this information clear, useful, and applicable to your practice. If you enjoyed this session, please like, share, and subscribe for more educational content. Feel free to review your questions or topics you would like to see next. Thank you again, and I will see you in the next lecture. Bye-bye.